So, a lot of talk has been made about siRNAs, especially in ophthalmology, and we've had some successes in this field, but not many clinically. So there are a lot of questions around why. Dr. Mitra did a very good survey of the various biological platforms. I'm not sure which one works for the, that's the one. And so I don't have to go over the various forms that we have, but when you look at the percent that are ocular trials, you see that we predominate in the siRNA space with 42% of the active trials listed in clinicaltrials.gov being for ophthalmology. And then the other is in aptamers, which we know Macugen and Fovista are the key contributors to that heavy size. And then gene therapy, we see a respectable increase. I don't want to make somebody blind. So let's just talk briefly about some of the basics of siRNA. We kind of all know about this, but sometimes focusing in on this aspect may help us understand where the problem areas lie. We know about Mello and Fire being awarded the Nobel Prize in 2006 for the RNAi approach, namely the siRNAs. There have been some characterization of siRNAs relative to understanding the structural features that are optimized and then the relevant therapeutic targets for this approach. We know that there are target tissues where siRNA would be optimized. So when we think about what makes a good siRNA, we have to focus on these key points. One is the length of the duplex is very important, whether there is a blunt or overhanging type of oligonucleotide strands in the complex, and then whether there are significant modifications to the base residues to reduce exo and endonuclease degradation. And then fourth, which is really important, the sequence residues for the selectivity against the target and the minimization of potential activation of immune response. We have a cartoon here depicting some of the salient features of an siRNA. And when I mean overhang, we're talking about two nucleotides that overhang on the 3' ends of the molecule for both backbones. So we have blunt, which is this type of configuration, versus the overhang. These become very important. And then, of course, the size, 19 mer to 23 mer, we have some literature around size being important. And then the molecular weight range from 13 to 15 kilodaltons. So delivery, that's always the challenge for molecules for ophthalmology, and this is no exception. siRNA has been explored not only for ocular diseases, and for these non-ophthalmic diseases, some facilitation of entry into cells has been required. For in vitro studies, transvecting agents such as lipofectamine and others, which have a lot of positively charged functional groups, aid in the electrostatic attraction to the negatively charged surface of the cells. And then endocytic entry pathways are theorized to be operational there. Some have used electroporation with some limited success, although the expression level is usually very low. What's interesting about ophthalmic treatment approaches is that we have demonstrated both preclinically and in the clinic that so-called naked siRNAs do enter into ocular tissue cells, and they do have significant downregulation of target genes in the eye. So we have an advantage in that realm. So there are barriers to molecular clearance, pathways and entry. We know about the enzymatic instability of siRNAs, which were mentioned. And we have specific foreign body clearance mechanisms like RNase H and the toll-like receptor or pattern recognition receptors that are ignited when we see double-stranded RNAs, especially the immunogenic sequences like CGs that may incite the bacterial and foreign cell and particle type of immune reactions, and then phagocytosis, which also plays a role. For the physical barriers, a vascular endothelium is very important. Some key areas that we know about are the tight junctional barriers, which restrict paracellular entry to less than 5 nanometers in size. And we all know about the liver. It seems like the liver gets everything because it's a fenestrated target tissue, and anything that's macromolecular, pegylated, everything loves to collect in the liver. Here we have a cartoon just kind of highlighting some of the salient parts of the mechanism of action of this approach. And if we begin with looking at a double-stranded RNA, maybe 30 mer in length, we theorize receptor-mediated endocytosis for entry into the cell. And then an entity called dicer cuts this into a smaller siRNA, about 22 mer in length. And then we have a species called the RNA-induced silencing complex. This resides in the P-body organelles in the cell. It has Argonaute 2, which is the binding site for the guide strand of the double-stranded siRNA. And then once it binds, I can't see it from here because I'm kind of looking over the thing. I think you can see it. There's a helicase mechanism that separates the two based on thermodynamics, and then the passenger strand is degraded. Once this guide strand is attached to the Argonaute 2, it becomes an activated RISC complex. Then it begins doing sentinel-related work, looking at mRNA within the cytosol that have complementary to the guide strand, which is in the RISC. And once this happens, it has targeted degradation of the mRNA and inhibition of transcription. The molecular factors that we must consider, and I'm trying to be cognizant of time, are, of course, size. I think that we all are aware of small molecules around 500 Daltons relative to siRNAs, which are quite a bit larger at 13 to 15 kilodaltons, and then Mabs at the big monsters at 160 kilodaltons. So charge still plays a role with large as well as small, impeding transcellular uptake. And then linearity versus branching and folding or conformability play a role for the larger substrate. Dr. Saldari, I can't remember your name, she gave a really good discussion about deformation of molecules, how erythrocytes can transport through the venules and capillaries of arteries and venules, because the size of a lot of the substrates in blood are a lot bigger than actually the diameter of the vessel. So this also plays a role in how macromolecules can transverse in the blood when you think about the physical size and the dynamics. The hydrodynamic radii play a role when it comes to charge, such that the oligonucleotides have a high charge, and so they are, quote, bigger than their actual size. So that impedes some paracellular pathways. So let's look at some of the in vivo evidence. First, there's not a lot of data showing a robust study of ocular PK of siRNAs, and really that's a key measure for activity. And then we're going to look at the retinal disease models, looking at substrate siRNAs that were also tested in the clinic. Here we did some work which was published in IOVS 2014, this year, where we looked at target siRNA against RTP801. It's an inhibitor of mammalian target of rapamycin complex 1. This siRNA called PF045-23655, that's Pfizer jargon. Basically, we looked at the pharmacokinetics on the left side of the axis in retina, and then on the right, the RTP expression, RTP801 percent expression of control. And so you see a hysteresis type of relationship. The tissue concentrations go down very rapidly after intravitreal injection. However, the inhibition activity is prolonged up to 14 days in the retina, and then RPE choroid up to 21 days. So this really bodes well for an siRNA approach. The learnings from this modeling is that the transcriptional half-life of attenuation in the retina was 3-fold to 70-fold greater than the pharmacokinetic half-life. So this is consistent with the risk mechanism of action, the sequestration of the siRNA into risk. And we confirm that these target tissues, which are neuronal type cells, are non-dividing. Thus, the risk machinery is not diluted and allows for a persistent activity. This all sounds great. So what's the problem? Why have most siRNA trials failed? When we examine some of the preclinical studies that have been done, this is a mouse laser-induced CNV model using the siRNA 027, which also went to the clinic. It's a typical design, intravitreal injections at 1.5 versus 3 micrograms, and looking at it over several days, harvesting the tissue as well as looking at flat mounts. And they saw reduction in the VEGFR1 mRNA copy number, which was robust. But if you'll note, the 3 microgram dose was 57% inhibition, and the 5 microgram dose showed 30% inhibition. So there's not really a good dose relationship there, which may bode for additional questions about the mechanism. Oh, I don't know what happened there. That's not what I had. I think that's a corruption somehow. But similarly, they used another measure called neurovascular measure of area, and it was consistent. And now we have another siRNA called bevacizumab, also known as CAN5, which is also against the VEGF target. And they show robust dose-related inhibition of the leakage or the formation of neovascular lesions. And then for the RTP801 siRNA PF655, we also examined it in a laser-induced rodent model, a Long Evans rat. And what we observed was dose-related inhibition in the retina. However, we didn't see inhibition in RPE choroid, which is a problem since it's a target we're looking at for wet AMD. However, interestingly, we did see drug-related inhibition in the incidence of grade 3-4 lesions, as you can see here, 86% inhibition, but 37% for a higher dose, and then 75% for the highest dose. So it was drug-related, but the dose relationship was not clear. Just as a quick summary, when we look at the clinical outcomes of 027, the mRNA against VEGF, we see that the structural differences is a 21-mer, which may be susceptible to the toll-like receptor type of activity, which would be non-MOA related based on studies by Embody and others that have been published. So that may have confounded the outcome of translation from the preclinical studies to the clinic. The status of this is it's halted because it failed to meet key efficacy endpoints. And then the other is the bevacizumab, which is against the VEGFR1 target. There may be a question around robustness of this target as far as activity for VEGF. VEGFR2 is known to be the most important. So it may be a combination of that versus a 21-mer structure that kind of caused this to halt. And then we didn't see good visual acuity gains with the substrate. And then lastly, the RTP801 target, we don't know if this is the optimal target again for the disease. In wet AMD, they didn't really see a good signal based on the Monet study. It was a very small study, however, no significant difference from combination with ranibizumab. And then the Degas study, which is in DME, also showed some activity, although the number of letters of visual acuity gains were very low. So we're awaiting the results for another trial that they have run in DME before the jury will be in on whether it works. So in summary, the siRNA platform has been extensively studied. In theory, this approach has a basis for potential success. Important in the success is the target chosen for the siRNA mechanism, as well as the structural characteristics of the siRNA. Preclinical studies have not been as predictive of the clinical success as envisioned, on my timer. And then key studies are still needed to highlight areas to improve activity. These were some of the contributors for the RTP801 work, my collaborators at Pfizer. Ted Johnson, who did a lot of bioanalytical analysis work. Paolo Vicino, who did the PK/PD modeling, which was really key to getting some good information from the study. Brad Hirakawa did the qPCR, and Dalia Kalabat, the laser capture microdissection, as well as Amy Yang. And then Wenhu and Tony Basil and myself did a lot of the conceptualization work for the study design. Thank you very much.
Yeah, we have time for a few questions. Go ahead.
Hi. So, have siRNAs been used to target the front of the eye?
There are some preclinical studies that have been reported examining it in the front of the eye, and it looks promising in that realm as well. There's no reason why it wouldn't work, and it might be even easier.
Yeah. How would it deliver? Just topically, or injection in the anterior chamber, or? So
what's great about diseases like dry eye disease is an ocular surface type of disease, so a topical approach would definitely work. As far as penetration following topical administration, there might be some detectable levels that would be quantified. It's interesting how sometimes large molecules can somewhat get into the back of the eye, but likely to be low.
Thank you for the presentation. I have one question. Could you explain any possible reason why there was no dose dependency?
So the explanation that we gave in the paper was that, one, the outcome measure that was used is very subjective. You're looking at a clinical read of whether they had a certain grade of leakage in their retina. So that's subject to some variability. And then the nature of these laser CNV models is kind of variable, so you have to do it a number of times to get a really good read. And we have some unpublished data actually in a murine model where the dose response curve was much more consistent. And that measure that was used was the area of neovascular lesion. That's a little bit more quantitative.
Okay, and one more related question. I assume that it was intravitreal injection of siRNA directly.
Yes.
Without any formulation.
Right.
So the siRNA, were they modified so that the charge was the total charge was neutralized or close to neutral?
So I don't know the pH of the molecule, but I know that it's O-methyl modified throughout.
Okay, so it's neutral most likely.
Right.
Thank you so much.
Yes, you're welcome.
Very nice presentation. It's a question maybe you and Dr. Mitra can address together. So when you deliver siRNA, which would be the route of preference for going into the back of the eye? Would it be a topical or intravitreal? And why would you prefer that?
Yeah, I don't think it's really a matter of preference. It's basically that getting these substrate into the back of the eye are very challenging, and an intravitreal dosing schedule allows for more direct access than topical. But based on the information that was presented by Dr. Mitra, perhaps this new carrier system might be something that could be explored. I don't know if it could make it for topical to the back of the eye as well.
Right. We are now working on that to see what is the siRNA is not that big molecule. It's in the middle, and maybe you will be able to do it with siRNA. We haven't explored that yet, but the large proteins is very difficult to go from topical. It has to go into intravitreal. Yeah.
Right. I think we would prefer a non-invasive type of delivery, but just not feasible.
Thank you. The other question I had was, what was the duration of efficacy in terms of the regulation of gene expression, whether in the front or the back of the eye? Did you see any difference in that?
So for the preclinical studies, what we did, the plot that I showed you that looked at the time course, let's see if I can maneuver this thing. Whoops. Before this one right here. So this is our attempt to understand the kinetics of silencing. So when you look at the right axis, that tells us the inhibition of the RTP801 expression. And what we saw was in the retina, we saw that it actually lasted or persisted all the way up to almost day 14 in the retina and out to day 21 in the RPE choroid. So there's a paper by Bartlett et al., I think it was published in 2006, that talks about the kinetics of siRNA, and they did a really robust study that was really pretty that described the difference between non-dividing cells and dividing cells as far as siRNA risk-related activity. Because neuronal cells don't divide, the risk, in theory, would stay activated and work longer. So typically, with this, a 17-fold difference in the kinetic versus the pharmacodynamic half-life is huge. So it should last and persist a long time. The challenge is the PK may not be as robust assessment in rodents as it is in another animal. So we need to understand the PK better to understand the translation to the clinic.
Right. I think the point of cells dividing versus non-dividing is very critical.
Yes.
We have published a paper a couple of years ago showing siRNA can persist and its activity maintained for 6 weeks. And so we have performed 3 deliveries over 3 months. Wow. And the activity was maintained. These are in the rat eyes, yes, and in the vascular cells through intravitreal injections of siRNA.
Yes. So the other question I have for you then,
yes,
is, what about the activity, the knockdown? Is it very robust? Is the copy number extensive? I think maybe that may be the key issue why we don't see really strong signals.
Yes. 2 things are here. One is in the retina, the endothelial cells in the vasculature divide very infrequently. Reports from Pat DiMori has shown that these cells actually divide once a year or even twice a year. So they're very, very stable as opposed to endothelial cells in the other parts of our body, which are dividing rapidly in 2 days. So depending on the area of the body, the cell division, the cell cycles change, even though they are same endothelial cells. That's one. The second thing was, yes, there was a significant reduction. This was extracellular matrix proteins, fibronectin in particular. And not only that, but we were able to reduce pericyte loss, acellular capillaries, and prevent apoptosis and reduce basement membrane thickness by this approach.
All right.
Yeah.
So we need to enlist your support so we can get some clinic results.
We'll be happy to.
Thank you.
One of the things that I want to point out that macromolecules, for example, if you look at the bevacizumab or full-length antibody Lucentis, the half-life is 7 to 10 days in the vitreous. So that means it's cleared very rapidly, and we find that it's going to the retinal circulation. It's not going into through the aqueous pathway from the front. It is going to the back. I do not know, do you know why siRNA, which path it takes? It goes through the zonular region, the lens, and then go into the aqueous humor and then excreted, or mostly go through the retina?
That's a good question. We did the PK in rabbit and showed the tissue distribution in almost all the targets. Mm-hmm. Now the pathway, there's some debate around things like Mabs, that they believe that some of the distribution is actually through the aqueous, mm-hmm. And then going back the other way. But the evidence, I think, supports that it gets into the retina from the vitreous, as well as some getting escape into the aqueous. I would suggest that that would probably be similar for the siRNAs as well. But as far as the predominant path, it might be aqueous because, you know, a lot of these tend to have almost 100% bioavailability. So probably most of it just gets into the systemic circulation. And there's not any metabolism, at least for most of these, in the eye. The vitreous.
You have a question there? Just last question, yeah. Go ahead.
Do you have any recent report about siRNA delivery by conjugation to cholesterol, and people were working at like, do you have any information?
Not that I know of, but I know there are some other people that are going to be talking about siRNA delivery, I think through nanoparticles, isn't there? Somebody speaking?
Yeah.
Conjugated in liposomes.
Oh, okay. No, I'll be keenly listening. I have not.
Is next
Thank you.
speaker available?
Thank you very
Okay.
much.